If you're watching this, you probably have access to healthcare. You may have a private GP, you may see specialists promptly, you may even undergo regular executive health assessments at very good clinics. Or you may use a public system and still receive competent, conscientious care. But regardless of how your care is organized, a surprisingly similar experience happens to many adults somewhere in their late 30s or 40s. You begin to notice changes. You're more tired than you used to be. Your recovery is slower, your body composition shifts despite similar habits, and your concentration is less sharp late in the day. You feel not ill, but not quite the same person you were 10 years ago. So you do a reasonable thing. You consult a physician. You bring your laboratory results, you undergo examinations. And very often you hear a phrase that is technically correct, but psychologically unsatisfying. Everything looks normal. Not infrequently, people interpret this as dismissal, but it actually is not. Your physician is not ignoring you. They are practicing medicine exactly as it's structured to be practiced. The difficulty is that the question you are asking and the question medicine is designed to answer, these questions are not the same. Today I want to explain why a competent specialist, or even an excellent one, often cannot meaningfully solve aging, and why this is not a failure of the doctor, but a mismatch of objectives. Modern medicine is an extraordinary achievement of specialization. If you develop an acute heart attack, a cardiologist can restore blood flow to your coronary artery in minutes. If you have a malignancy, oncology can deliver highly targeted therapies unimaginable 50 years ago. If you need surgery, highly trained teams perform complex procedures safely every day. This is not theoretical success, this is real life-saving competence. But specialization has a structural consequence, with each specialist responsible for a defined domain. The cardiologist evaluates cardiovascular disease, the endocrinologist evaluates hormonal pathology, the neurologist evaluates neurological dysfunction, and your general practitioner coordinates and screens for identifiable illness and refers appropriately. This system is extremely effective at detecting and treating disease. However, the experience many adults describe is not a single disease. It is a gradual change in resilience, recovery, and capacity. No single test becomes clearly abnormal, and therefore no single specialist has a clear problem to solve. The medical system is built to identify defined pathology. It is not built to continuously interpret subtle shifts across multiple systems over decades in otherwise functional individuals. That is not negligence, it is the architecture of the system. A second issue emerges from something patients often misunderstand: laboratory reference ranges. When your blood test returns normal, you may assume this means optimal. However, it does not. Reference ranges are statistical boundaries designed to detect disease, not to define peak human function. For example, a laboratory value may be considered normal because it falls within the distribution seen in a large population that includes individuals with varying lifestyles, health habits, and early physiological changes. Normal often means no diagnosable pathology is currently identifiable. It does not necessarily mean this value corresponds to the level at which you personally feel or function best. This creates a situation many professionals experience. Their tests are technically reassuring, yet their subjective performance declines, and both can be true simultaneously. Your physician is answering the question, do you have a disease requiring treatment? But you are asking a question, why do I feel different from my earlier self? Medicine is extremely strong at the first question, but it is less structured to answer the second. Consider glucose metabolism. A hemoglobin A1C may be within the non-diabetic range. That tells your clinician you do not meet criteria for diabetes, but it does not describe day-to-day physiological variability, recovery after stress, sleep quality, or the interaction between workload and metabolic responses. Similarly, cardiovascular disease does not begin when a symptom appears. It is a biological process that begins very early in life. Autopsy studies have shown fatty streaks and early coronary artery plaque already present in childhood and adolescence, and in some individuals, substantial atherosclerosis can be found in their 20s. Even young soldiers who died in combat, physically fit and outwardly healthy, were found to have coronary plaque, despite their age and conditioning. The disease, therefore, exists long before a person could reasonably suspect it and long before clinical detection is possible. So when somebody is told you have no heart disease, the correct interpretation is often no clinically detectable disease at this time. This is a different statement, and this difference is psychologically difficult because a person may sense change long before medicine can even define a diagnosis. Medicine acts when thresholds are crossed, but human experience changes before thresholds even exist. A similar timeline applies to neurodegenerative conditions. Alzheimer's disease, for example, is not fundamentally a disease of old age. It is a disease whose biological processes begin in midlife. The initial pathological changes, amyloid accumulation and later tau-related neuronal injury, develop silently for years or decades without symptoms, followed by a long period of very subtle changes that are often interpreted as stress, fatigue, or normal aging. And only much later, typically in older age, does the condition become clinically recognizable. The diagnosis, therefore, appears late, but the disease itself began long before recognition was possible. The medical system is designed to intervene when evidence is actionable, whereas patients often want interpretation when uncertainty first appears. Those are different stages. Your physician is not refusing to help. Your physician is practicing within evidence-based framework. Acting too early without sufficient indication carries harm. Acting too late carries risk. Balancing those is the core challenge of clinical medicine. So what is actually happening in the situation many adults find themselves in? You're encountering a boundary between the two types of medical thinking. One is diagnostic medicine. Diagnostic medicine asks, is there a disease and what treatment is indicated now? The other is interpretive medicine. Interpretive medicine asks, what is the trajectory? What risks matter? And when should action become necessary? The first is well defined in clinical pathways. The second is less visible but constantly present in experienced clinicians' reasoning. And this is why many people feel confused. They're not seeking treatment yet. They are seeking orientation. They want to understand. Is this expected aging? Is this lifestyle? Is this early disease? Is this important or is this noise? Those are legitimate questions, but they are not questions a short diagnostic appointment is structured to answer comprehensively. So the phrase "everything looks normal" often means something more precise. At present, no identifiable disease requires medical intervention. It does not mean your experience is imaginary. It means it has not crossed the line where treatment becomes medically justified. This is uncomfortable because human perception notices gradients while medicine operates on thresholds. You feel the gradient, medicine acts at the threshold. What then is the useful role of a physician in this stage? Well, not to replace your treating clinicians and not to provide treatment remotely, but to help interpret the context, to help you understand which changes are expected, which are concerning, which require discussion with your own doctor, and when evaluation becomes necessary. In other words, not to practice medicine at a distance, but to make medical decision-making intelligible. Many high-functioning adults do not lack healthcare access. They don't lack test results, data, or information. What they lack is clarity about how to use healthcare appropriately. When to investigate aggressively, when to observe, when to modify behavior, when to ignore noise. This is not a protocol question, it is a judgment question. And such judgment is built from pattern recognition across many patients over time rather than from a single laboratory value. Specialist physicians are excellent at managing disease in the present. They prevent catastrophe, they restore function when illness appears. But if your goal is different, maintaining capacity and resilience across decades, you need to shift from treatment to understanding. You're no longer asking what medication do I need, you're asking what matters and what does not. And that requires a different type of conversation, not replacing your clinician, not bypassing the system, but being able to approach your own physician with better questions, clearer priorities, and appropriate timing. The aim is not to medicalize life. The aim is to navigate it without unnecessary fear and without avoidable neglect. In other words, we're moving from reacting to abnormal results to understanding when results truly become meaningful. Because health decisions are rarely binary. They're usually about thresholds, and understanding these thresholds is often more valuable than chasing the numbers. If you feel well, continue routine care with your treating clinician. If you feel persistently unwell, that always deserves proper medical evaluation. But if you find yourself in the space between illness and confidence, where the results are normal but uncertainty remains, you're not unusual. You're encountering the limits of a system designed to treat disease when it appears, not to interpret every stage of human change before it does. Understanding that difference often reduces confusion and sometimes clarity about what a doctor can and cannot reasonably do is the first step towards using medical care more effectively.